Do you guys have another package on delirium? I love this picture, right? Because when we think about delirium, we're going to look at some of the causes of delirium, right? And I really want to talk about what it looks like. So what does delirium look like on your unit?
Sudden onset change in behavior or cognition.
What does he look like? Okay. Okay, excellent. Agitated. What does that look like? What is agitated?
Calling out.
So you guys are going down the right track. That's it, right? That's that change from kind of their norm, right? So we see a real change in the behavior. The staff will usually say to you, something's up with, you know, with Fred, something's just not right. I got that gut feeling. Your gut feeling, you ever have a gut feeling about somebody? You just can't put your finger on it. Always a good time to start doing an assessment, right? So we know so delirium, we know it's a disturbance in attention and awareness that develops over a short period of time. So I'm not looking back 1 year, because if I'd be looking at a decline in cognition, right? That I'd be looking at more of a dementia. But I'm like this today, and I look like this tomorrow. It is a medical emergency, right? So I know all of a sudden I've got slurred speech, not feeling good, my vital signs may have changed, right? I'm not the same, change in cognition, I'm confused, I'm restless, I'm calling out, I'm fidgety. All of these things, I've had this really big change, right? That's where it starts becoming challenging, right? That's where you guys become these great detectives to work through this, right? So we do know it's a short period. It represents a change from the baseline, right? I really want to stress it's a change from the baseline. We're looking at the change from that baseline, okay? We know it's a medical emergency. So I'll use the 3-question template. So when somebody calls me or we're starting to talk about it, so I'll say, okay, so what has changed? What has changed with the residents? So I might be somebody who paces. This is great though, Netta, right? So I might be somebody who paces normally and wanders normally, but now all of a sudden I'm really intense and I'm really pacing. That's the change from my baseline, right? I might be somebody who's aphasic, but I could communicate a little bit, but now I can't communicate at all. I might be a little bit restless, which is kind of my norm, but now I'm striking out, right? Because if I can't communicate with you verbally, right, and I've got advanced dementia, what do I have left to communicate with, right? So I want to know, is this problem, is it already here? Has it always been happening? Is it worsened, right? Is the behavior long-standing and unchanged? So that's part of my 3-question template. So 1, what has changed? New behavior or new problem? Has the problem or the behavior already been there, right? Is it a long-standing? Is it unchanged? So those are just some questions to work through. And these are questions you don't have to have a meeting. You can have a quick, hi, what's going on? What's changed, right? Yeah, and using your PSWs, right, they know those residents. They are our eyes and ears, so really take the time to speak to your PSWs. We need to open up those lines of communication with our PSWs, you know, and sometimes I know we're really busy and I know we're running around and just saying, okay, you know what, when I do the ABC meetings with the team, I really talk about communication. So she's a PSW, what does she need to do on point of care? Chart. She's got a document. She can set an alert. All the PSWs know how to go into point click care and document, and I may say to Netta, that's great. You've got it in point click care and you've documented, or you have it in point of care and you've documented it in point click care? Netta says yes, I've done that, and I say okay, that's great. I need to say thank you to Netta, and we need the PSWs. We need to open up those lines of communication. It's about mutual respect, right? So we want to talk about risk. So this is our 2nd question. So I do risk assessments all the time, just because that's my role. So somebody will call me and say, you know what, Samantha, this is what's going on with the behavior, and I'll talk about risks. So evaluating risks can also help look at how urgent the situation is, right? So risk, roaming, wandering, are they out of the building? Are they adamant to get out of here, right? Are they at risk of injury to themselves or others? That's usually my first question, because we have that a lot here, right? Are they going to harm a co-resident, right? We have a decision tree through the Ministry of Health when we're talking about these altercations and what to do. So we actually have to do something. We have to intervene. Are they at risk of suicide? This is key. This is an emergency, right? So we talked about relationships, right? So risk of harm by the person or to the person. Okay, so what is the action? This is key, right? So what are our interventions, right? So when we're looking at a delirium, so what are our therapeutic approaches? So what's our non-pharm approach to this situation? So if I have a resident and they have delirium and it's related to pain, how effective is trazodone? Seroquel, all of those things, not effective, right? So I need to, now I'm on that investigation. I'm trying to find out the why behind the behavior, okay? So what other investigations need to be completed? So I'm looking at the resident, they've got delirium, we've identified, right, what some of the concerns are here. Where do we go first? What do we do? How do we communicate? So what are our interactions, right? So communication and interaction strategies for the resident and our team, and information. So how do we collaborate as a team, staff, family, physicians, right? So we're going to get into that. So this is the assessment we do for our residents, right? So I've got a resident with delirium. Where do I start? Where does everybody tell us to start? I've got a change in condition. Net has just changed. What's the first thing I do?
Assessment.
Yeah, right? Frank just said visual, right? That visual look, right? You need as a nurse, so if I tell you that Fred's condition has changed, you need to go into the room and physically look, assess vitals, right? And I'll say, people say to me, well, this, and this is going on. I'll say, that's great. I just need to look at them. I just want to look at their affect. I just want to look. No, Samantha, no, let's make some med changes. No. I need to go and look at my residents. So as a nurse, you're responsible, right? We're held accountable to the College of Nurses. We have to go do a nursing assessment, right? Our SBAR that we do, that we're going to do in the N2, speaks to that, right? You have to do a nursing assessment, right? So when we work through a PIECES assessment, it's a template. So it just kind of helps us guide our assessment, right? So this is kind of what it feels like. I got a resident with delirium, and here is that vicious circle. Where do I start? Mobility, is it dehydration? Is it sleep? Is it constipation? Is it like pain, malnutrition? Where do I begin? Where do I start? This is really challenging for us because I think sometimes it can be really overwhelming. There's a lot of expectations for us, but we can work together as a team. And we have a phenomenal team here at the Pearly, right? So physical, we look at the 5 Ds, right? So the delirium, disease, drugs, discomfort, and disability. Right, so we're looking at disease. So what are some of the diseases that can cause a delirium?
UTI.
Okay, what are some medical diagnoses? Right, so if I have diabetes, may I potentially be in a delirium at some point?
Yeah.
Why?
Blood sugar.
Blood sugar, right? Do you know sometimes somebody's blood sugar's out of whack just by their behavior? Drugs, so we know medications, right, can cause a delirium. What are some medications that can cause a delirium?
Any psychotropic.
Narcotics, yeah, any psychotropic, exactly. Cheater, right there, Nana. Right? Yeah. Discomfort. So if I have pain, pain is key. However, when you're doing your assessments, it really needs to go urine, pain, bowels, pharmacology. That's an equal playing field. Abby pain scale. Do I do the Abby pain scale when they're sleeping?
No, if they're sleeping, they're not in pain.
Do I move my resident when I do a pain assessment?
Yes, you should. Yeah.
Because if I don't move, nothing hurts.
Right.
But if I do move, that's a concern, right?
Yeah.
Right, so discomfort and disability. So causes and possible causes, right? Stroke, TIA. MJ, mass bleed in the brain, right? So document what you're doing and care plan it, right? So we talk about causes of delirium. So if I have a resident who's just stopped eating, call the dietitian, I need to change their diet. Look in their mouths, right? Do they have an abscess? Especially, I love when they have dentures, right? I really do, sadly, because when their teeth start breaking off and they start getting abscesses, a lot of our residents will get thrush, right? See thrush in long-term care because they don't have the ability, right? That reflex for swallowing is gone. They may drool. They've got lots of different medications. They might be dehydrated, so it puts them at risk of thrush, right? So look in their mouth. Dry, itchy skin, hypoxia, right? Anemia, dehydration, constipation, sleep. I don't know about you, but if I don't have enough sleep, I'm possibly not even a human being, right? So think of these guys who are up all night, restless, no sleep, And then we want them to participate in the activities of daily living and all the rec programs that we have for them, right? They can become responsive, right? So changes in medication. What's a rule about med changes? What's a great rule for medication changes in the elderly? So we know that surgery, so we have our post-op delirium. So we send a resident to the hospital, they have a hip fracture, how soon are they back?
Next day. Same day. Depends on if they have surgery or not.
Yeah, right, quickly. So we're looking at a post-op delirium is very challenging for our residents. We change a resident from unit A to unit B, right? Physical restraints can cause a delirium, catheters, lights, noise, smells, right? Pain is number one. I've got to rejig this slide, and emotional stress, right? So we have some tools. So in your package you have iWatch Death, CAM, and the Delirium Decision Tree. These are great tools. I'll come out, I can do a CAM. Has anybody done a CAM before? So it's the confusion assessment method. It's quick, it's rapid. So you have the tool in front of you. If you need to use it and you're not sure about delirium, it's a quick couple questions template. It's super easy, very simple to use, right? iWatch Death is a little checklist that you can go through that you have in your package that speaks to some of the different causes that may potentially have caused a delirium. It's good to work through, right? So they'll talk about infections, withdrawal, any electrolyte disturbances, right? So I got a potassium of 6.5, what's happening? My old ticker's going, right? Something's right. I've done, I do the electrolytes. I look at their electrolytes and they're severely dehydrated, and then I go to point of care and I pull up, I love point of care reports. I pull up their intake list and I see like nil for fluid intake, right? Everybody know how to pull off the bowel sheets off point of care? Excellent tool. I just showed 2 RNs yesterday how to pull up the BMs. It is a great, because you can actually see a pattern. And we were able to look at a pattern of a resident's bowel movements. She said, and the staff said, oh, he's great, he's good. I said, 1 BM, none. So, we don't assume things, but here's, so I will assume a resident has pain until you can prove to me they don't. That's my rule of thumb. Prove to me they don't have pain. Okay, Netta's constipated. How do I know? I'm just going to go with constipation until you can prove to me. Give me some facts. Okay, bowel sheet's good. All right, abdo x-ray is good. Okay, or rectal exam is great. Palpation of the abdomen, auscultate. Okay, good. You're all right. Chances are maybe she's not constipated. Abdo x-ray's clear. Okay, I'm good. She's not constipated. I move on. That's how I work through my processes. I assume that this is what is going on, and then I'm going to withdraw. So your decision tree, so very quickly, right? So you can go through your 3Ds quickly, right? Look at it. We talked about it. Altered mental status, yes or no. Inattentive, flight of ideas, right? Disorganized thinking, rambling and unclear, yes or no. Altered level of consciousness, okay? It gives you really good, urgent, right? We talked about it. It really turns to, if I'm answering yes to any of these, then I'm going to be calling the physician anyway, because you guys are really good to say, hey, there's a change in condition. I'm concerned we need to do some assessments, right? Or if it's not, if you answer no to these, you can still kind of work through your process. This is from the RNAO Best Practice Guidelines, okay? It's really good. It's a great tool to use. Some intellectual things that we're going to be looking at with our resident. Absolutely. So that's great. I'm impressed that you got, they're tough to remember. I'm going to ask you guys in a week. Well, remember amnesia. So amnesia, aphasia, apathy, agnosia, apraxia, anosognosia, altered perception, attention. So when we look at that PIECES assessment, we look at all of these, right? I look at these all the time with our residents. Is there any change to all of this? Are they now aphasic? Why are they aphasic, right? Were they able to remember and now they can't, right? They used to be able to participate in care and now they can't, right? So some of the challenges, they used to be able to sit and now they're pacing. So why the change? That change from baseline. Emotional, right? The disorder adjustments, right? Disorders of mood, so depression, that somatic presentation, anxiety and grief. If they're delusional, right? Personalities disorders, I think that's what we're dealing with a lot of in the Ottawa 1 East. You're dealing with a long-standing psych history, right? We are seeing it here that not often, but when we're seeing a resident who's elderly with a long-standing history of schizophrenia, their capabilities, so their ADLs and their IADLs. Anybody know what IADLs are? Not Netta?
Internet,
IADLs,
instrumental
activities.
of delirium.
What are instrumental activities of daily living?
Am I allowed to talk?
No, Netta's dying and Netta's burning over here.
Instrumental would be what? Things that they need, things that they use, how,
Okay, Netta, go.
It's like paying your bills, preparing your meals, things that aren't like just your care. It's things that
outside.
are
Okay.
other than care, like doing your laundry, paying your bills,
Grocery
doing your
shopping.
banking, grocery shopping. preparing
So
meals.
we don't tend to see this.
Instrumental.
Instrumental activity.
Instrumental.
We don't tend to see this in long-term care because they have lost those abilities to participate in their IADLs tends to be why they're here, right? So they can't do those, so that's why they tend to come to long-term care. There's a few, there are a handful of residents who still pay their bills but really we provide a lot of services for them, so we are focusing on their ADLs, right? So care of the person focuses on function and abilities. It's important to approach each individual resident holistically, right? So we really need to look at a holistic approach to our residents, right? We need to know what they can do and then build on those strengths, okay? You must assess the resident and reassess their abilities and ensure that the care plan reflects these changes. Okay, you have care plan meetings, we have a great RI team here. So environment, right? Understimulation or overstimulation can cause a delirium, relocation, change in routine, noise and lighting, right? So any of those can lead to behavioral changes, right? Disorientation, frustration, and fear. Frustration for sure, right? We think of our residents. Think of your own self in your daily routine and how you get up and you start your day. If that routine is changed for whatever reason, how well do we function?
I'm not functioning.
And it's not happening, right? I don't know about you, but when I get up in the morning, I have a process, right? So when I change that routine and somebody who's been on this earth for 80, 90 years, we have to be careful to make sure that we have them participate in their care plan, know what their routine is, know what's important to them so that we can do our best to meet those needs, right? I tell you, we're not getting along in long-term care if I don't have a cup of coffee, right? My hair, I can look like Tina Turner in the morning, it does not matter. I want a cup of coffee. I literally crawl to the coffee pot. And my kids will even say to me, "Can I talk to you now? Have you had some coffee? Is it safe?" Right? Just one more sip, right? Your routine, you might get up, the first thing you need to do is just stand in a hot shower for, 15, 20 minutes before anybody communicates, right? So changes in routine are key. That understimulation or overstimulation, we know when they're overstimulated, that can cause some challenges in responsive behaviors. All you need to do is be on a unit that has one resident yelling. Causes a lot of distress in the other residents on the unit, right? So social, so find out about that person's life story and their social network, right? We need to see what we can do to meet those needs. So if they were part of a club outside, can we facilitate that inside, right? Knowing what's familiar and comforting can help the staff to reassure and distract, right? So you can use these. So knowing about the resident, right? So I've read their care plan. What's a great tool to get to know somebody? I love this at the Pearly because it's outside everybody's door. Every resident has this outside their door.
A little picture of the cabinet.
That cabinet is amazing. So I'll stop, I'll have a resident that I'm just seeing, it's an emergency, I know nothing about them, and I'll stop. Cat, dog, military, engineer, family, kids. Okay, I've got some tickets to get into their world. Because if you're a resident with responsive behaviors and I know something about you, you may not know me, but I must be safe. You feel a bit more trustworthy if I know something about you, right? Documentation is key. We touched a little bit about documentation. So the Cohen-Mansfield is a really great tool. So you have it in there, right? So it's a great tool. So we use the behavior monitoring tool. We tend to do it for a week, okay? Documentation use to the point of care, your point-click care notes. So again, standard of practice is to document, okay? So you need to document, do your DAR charting, right? So what does DAR stand for?
Data action response.
Okay. Data, action, and response, right? So what is my data? What is my action? And what is my response? So my data shouldn't be agitated, period, response, trazodone, or action, trazodone, response, calm, period. I need to know, so if I'm in my office or anybody's here, so I call a unit manager, I'm having challenges with this resident. They can pull up on their computer, MJ, they go into the point click care notes, and they can look. A doctor outside of the home can look in. The ROH can look in and see those notes, right? So you get a great big picture. Makes so much more sense, right? And it's a standard of practice, right? We're held accountable to the College of Nurses, so we really need to make sure that we're meeting that, right? Care plans and making those care plans individualized and using the Cardexes. The Cardexes are great. If there's information that needs to be triggered to the Cardex, you don't know how, Netta can do some education. It's a great tool for the staff because the staff will say, I don't have time to sit down and read the care plan. Okay, I get it, but you can read the Cardex. Okay, I'm not saying that they don't have to, they have to read the care plans, but the Cardex is a really great tool to kind of meet those high risk needs, right? So that CMAI though here, so going through and actually putting words to their behavior, so instead of just saying they're aggressive, okay, what do you mean? Are they hitting, kicking, throwing, biting, scratching, spitting, pinching? So it'll help you kind of put the words to what aggression means and what are some of our non-aggressive behaviors. So what are the physical? So again, that pacing, that inappropriate distressing or disrobing, whether they're verbally responsive, right? And so it'll kind of help you really just pull it all together, okay? This here will help you do this tool. So that's your behavior monitoring tool. That's a standard of practice. That's best practice from the RNAO is that behavior monitoring tool. The other name for it is the DOS, which is the Dementia Observation System. And it helps us to monitor behaviors and patterns so that we can look to see, we monitor sleep here, we monitor whether they're calm, and then we'll monitor maybe 2, 3 other behaviors, not too many because it gets too confusing. We'll look at patterns and it'll really tell us, kind of help us track, right? It'll also help us track when maybe we should be giving a PRN, right? Once we've kind of got things organized. As care providers, we have to be the ones to interpret the message and we have to discover its meaning, right? So I can't do this alone. I can, as much as I'd like to think that me solely can do this by myself, it's not happening. I need a team approach, and that's where our ABC meetings come in. We'll get into that in a little bit. I need a team. We collaborate as a team, we work together as a team, and the team includes everybody on that team, right? And we have to work hard to identify those unmet needs and triggers, and it's tough. It's not easy, but you guys have great skills. Your nursing assessment is the key to that, right? And communication as a team. So communicate with your frontline staff, right? They'll help you.